Good afternoon. I'd like to welcome you all to this ESR Connect broadcast, and thank you very much for joining us. This is the second of a series of 4 broadcasts we're planning to try and assist radiologists who are dealing with the COVID-19 pandemic and to spread the knowledge that's been gained by our colleagues in those countries that have been particularly rapidly and severely affected by the pandemic, so that we can all learn from it when we face our own emergencies in our own countries. Last week, we had a very interesting and successful first broadcast during which Professor Nicola Lahti from Parma in Italy shared his experience with us. And Professor Sferzolati is with us again today. We'll also be joined by Professor Francesco Sardanelli from Milan. And we're planning to continue the theme of last week's broadcast by putting questions that have been asked by audience members last week, which we didn't get to both of our experts, and exploring some other aspects of management of COVID-19 pneumonia and related infections. So Nicola, Professor Sferzolati, thank you very much for joining us again. Perhaps for those people who weren't here last week, you could just give us a very brief summary of yourself and where you work.
Okay. Hey, good evening, everybody. So my name is Nicola Sferzolati. So thanks for having me here again. I'm a radiologist focused on chest imaging, and I'm working at the Academic Hospital of Parma, so one of the most affected area of the northern Italy, and would be happy to answer your questions.
Thank you very much. And our second interviewee today is Professor Francesco Sardanelli from Milan. I'm not sure if Professor Sardanelli is able to introduce himself at the moment. If not, we'll move straight on to the first question and come back to that. A question for both of our interviewees today, which arose from a discussion last week. How do you image patients who present at initial presentation if the patient is asymptomatic or relatively mildly symptomatic with COVID positive type symptoms? Do you image at all? Do you do a chest X-ray? Do you do a CT? Or do you reserve imaging of any type for patients who have significant respiratory symptoms or hypoxemia? So, Nicola, do you want to?
Yeah. Can you hear me, Adrian?
Yes, I can. Thank you.
All right. So, first question. Yes, we have set on an outdoor triage for clinical assessment of patients with respiratory symptoms. We do consider imaging only subjects with significant dyspnea or hypoxemia, so in patients with pulmonary damage, in other words, and the yield of imaging subjects without pulmonary dysfunction, I would think that would be very low, if not detrimental for efficient management of the referral fluid. So patients with minor symptoms did not undergo imaging and were safely managed with peripheral monitoring and less clinical worsening. However, we do acknowledge that in the setting of mild clinical features, imaging is advised for clinical worsening for sure.
Professor Sardanelli, are you online, or can you hear or see us? Okay, I know we've been having a little bit of difficulty with that connection, so we'll come back to that. CT is certainly more sensitive than chest X-ray for COVID-related changes, but many authorities are not suggesting that it should be used as a screening or a triage tool. I think to some extent you've answered that in your first answer by saying that you don't use any imaging in patients who do not have significant respiratory symptoms. But in patients who do have respiratory symptoms, do you have any views on the use of imaging to try and help make a diagnosis, or are the findings too non-specific for that? Is the PCR the key issue?
So you mean if CT or chest X-ray is sufficiently sensitive? So I didn't get your question. Sorry, Adrian.
Yeah, essentially, I think early on in this pandemic in Europe, there was quite a lot of commentary that suggested that CT could be used as a diagnostic tool in its own right, as opposed to relying upon PCR. I think there's been a bit more skepticism about that as things have developed. And personally, I think trying to use imaging to help make a diagnosis is probably a bad idea. But I'm interested to hear your viewpoint on that. Should the diagnosis be made by other means?
So I think that's for sure. Imaging should not be used as a screening tool. So the characterization of patients starts with the assessment of clinical evaluation, including oxygen saturation. And only a portion of these patients is then referred for further workup that might include radiology. So in our experience, at the beginning of this emergency 1 month ago, we all started with the PCR and the clinical evaluation. However, as you said, turnaround times for COVID testing results range between 6 and over 48 hours, with most sites waiting at least 12 hours for the results. So this approach was not fit for the overwhelming triage fluid and the need to stratify the risk for hospitalizing a minor proportion to limited hospital beds and ventilators, as you mentioned. So you have to consider presumptive provisional diagnosis, and in this scenario, imaging may play for sure an important role. So now the question is about whether use CT or chest X-ray for so as integrated for the clinical assessment and management of subjects with suspected COVID pneumonia. So that's the key question. Unfortunately, that I think nobody can provide a final answer. There is still a strong debate on that. So if you want, I can extend, of course, this key issue.
Well, please do, because you've kind of led into the next question that I wanted to ask. You mentioned that it's taking you between 6 and 48 hours to get PCR results back. And this is, I suppose, an allied question. If you have a patient who's suspected of having COVID pneumonia, who has respiratory symptoms, and in whom you have done CT imaging and found significant findings, are you then proceeding to treat that patient as having COVID pneumonia in the absence of a PCR diagnosis, or do you then wait for the PCR before you definitely label them?
No, we isolate and provide clinical support to patients while awaiting PCR results, for sure. And you know that therapy for COVID is still quite empirical, and as heterogeneous as radiologic opinions as well. So that is something that we have to do because, as I mentioned, as I said, the scenario had been varying week by week. So in the very first day, we used to get the results within 2 hours. 10 days later, we had been waiting over 20 hours or more for the results. In the last week, fortunately, this process turned much faster. So we are working in a highly dynamic environment where the status of regional epidemics and the availability of critical resources vary daily, let's say. But maybe you also heard about rapid point-of-care COVID testing. These are expected to be released into clinical environments during the first week of April, hopefully, providing routine turnaround time of less than an hour or as little as 5 minutes, that will also change our approach, I guess. So if we will have the results in 5 minutes or hour, that will also change our diagnostic and therapeutic approach for sure, rapidly.
So if I may summarize what I think I've understood, you've said if we try to put this in an algorithmic approach from a radiology perspective, if somebody presents with minor symptoms and are considered possibly to be suffering from COVID infection, but their symptoms are mild, you do no chest imaging. If they have significant respiratory symptoms, you will use chest imaging, chest X-ray, or CT, depending to some extent upon resources and upon their symptoms. But a PCR will be performed on a swab. But if significant chest findings on imaging are found, they will be isolated and treated as being COVID positive while you await the PCR result. Is that an accurate summary of what you're saying?
Yes, very accurate summary of what was said.
Thank you. And I think this is the sort of algorithmic approach that a lot of our viewers are hoping to take away from these sessions, that they can have a clearer idea in their head of how this should all be done. May I ask a question that's just come in on the live feed? How often do you see mediastinal lymphadenopathy in patients who are COVID positive?
Very sporadically. So, and I never seen very large lymphadenopathies in subjects with COVID infection. So I've seen some large lymph nodes in patients with multiple disorders. So you might be struggling with the differential diagnosis between lymphadenopathies related to COVID or related to other disorders, for sure. But I think that definitely lymphadenopathies do not represent a feature, a CT feature of COVID pneumonia.
Okay, that's very helpful. The questioner also asked, if you see mediastinal lymphadenopathy, would that make you think about bacterial superinfection, or is the pace of all of this too fast for that to develop?
Sorry, I think that honestly speaking, I have recognized superimposed infections in a very small minority of subjects. And I think that my guess was was not accurate at all. So the role of CT or imaging in assessing superimposed infection is, I think, is quite controversial. So I would not suggest superimposed infection, bacterial infection, on the basis of the presence of enlarged lymphadenopathies.
Okay, I've just received a note.
Contact the clinicians to discuss the cases. So we will need for further data to corroborate any clinical suspicion.
Thank you. I just received a notification that Professor Sardinelli is online now. Are you there, Professor Sardinelli?
Yeah.
You're very welcome. Apologies for the technical difficulties.
No problem.
Could you just briefly introduce yourself to our viewers, please?
I am Professor of Radiology at the University of Milan. My hospital is a mainly cardiovascular hospital, but as happened in these times, hospital with a different main mission were completely asked to become a COVID hospital. And so we had in the last weeks a lot of patients with hospital admission, and we remain as a hub for cardiac pediatric surgery and for electrophysiology, but for the other departments, we are a COVID hospital. I hope not for so many weeks, but this is the current reality. So my disclosure is that I'm not specifically an expert in lung radiology, but this is, I think, is one of the issues of the current times, because we are asked also to become experts very rapidly in fields in which that are not our cup of tea. But this is one of the change of the world in which we are living now. Okay.
Thank you. And I think the point you make is very valid. This is a condition that requires people who don't ordinarily do chest radiology to know what they need to be looking at, because we're all practicing COVID-related radiology, whether we like it or not now. Nicola and I have just been having a discussion about an algorithmic approach to patient presentation in terms of whether they need any imaging or not, whether it should be plain chest radiography or CT, and what to do about the findings. And one other question I wanted to put to Nicola about this was about patients who have a negative initial PCR. So if the initial PCR is negative, we're hearing that some patients may ultimately convert to being positive. So if you find a CT, if you identify CT findings that would suggest COVID pneumonia, but the initial PCR is negative, do you go ahead and isolate patients, treat them as being positive, and repeat the PCR?
But what happened is that also the chest X-ray can be positive with a negative PCR. One of the problem of this current condition is that, as I will show, if possible, with some of my slides, the standard is neither gold nor standard. So the reference is not always good, and this is one of the issue. But this is, as Nicola Svezzolati, Professor Svezzolati told us before, the problem is that with a very high prevalence, also the chest X-ray is already positive. So we did in the last weeks very few. I don't know exactly the number, but a couple of tens CT in cases in which the chest X-ray was negative. Because in the majority of cases, if you combine the clinical condition, the pulse oximeter, and the result of the radiographs, you have the results in your hand. The fraction of cases in which, in our experience, in this phase of very high prevalence, you need the CT for confirming a diagnosis are very few. This depends also on the thresholds for reading the chest X-ray, because what happened that during this week we lowered the threshold. I will show a case that was initially reported as negative, and discussing with my coworker now, we are convinced that most probably it should be considered, it had to be considered positive. But the PCR was changing from negative to positive to negative to positive. So it's a very crazy world.
Would it be fair to say that in a scenario like that, if you have a constantly fluctuating PCR, if you have any positive one, you must assume that patient is COVID positive and treat them as such, even if a subsequent one was negative?
One of the, if I correctly understood your question, one of the technical issues that we had in the last minute is that the number of radiographs, the number of chest X-ray I wanted to show you was a long series, because my intention is to show you that there is a very, sometimes there is a very little parallelism between the clinical condition and the chest X-ray, and I suspect also with the CT, because the discussion that we are having with our clinicians is that most probably in some of these patients there is some probably microembolism in the lung, for which the gas exchange is low, even in the part of the lung in which there is apparently a good parenchyma. So the correlation between the air in the lung and the condition of the patient is not so high. So I think that up to now, with some of the exceptions that I will show in the slides, especially for particular cases, the role of imaging is relatively low after the diagnosis is done. While when you are waiting for the PCR, a positive imaging study, mainly the chest X-ray, is absolutely useful for the clinician to make a decision.
Francesco, I know you have some imaging slides you'd like to show us. We can project those now, I believe. So if you could take just a few minutes to look through those, if you'd like.
Yeah. Okay.
Can we project? Yeah, thank you.
So I can share with you some very recent numbers regarding the current situation in Italy. You see the number of patients with currently positive for the PCR, the number of deaths, unfortunately, more than 10,000, and the number of healed persons that are fortunately more than the deaths. Among the currently positive, go to the next. Among the current positive subjects. No, go back, please. You see that there is a distribution between among 45 home quarantine, near to 30,000 hospitalized, but no in intensive care unit, and more than 4,000 in the intensive care unit. This is the situation now in Italy. So what happened in my hospital? Next slide, please. We had more than 400 COVID patients treated and over 150 admitted. Probably they are more than 300 now. So one important thing is go back, please. One important thing is where the hospital is located in Italy, because San Donato Milanese is in the southeast corner of Milan, and we are very near to Lodi and Codogno and the first red zone in Italy. This is an important point, don't forget this. So, next slide, please. So, one of the points is that what happened in my hospital immediately, about on March 9, we reduced by 95% the outpatient radiological work, with the only exceptions of urgent or high priority examination, mainly CT, very few MRI, very few ultrasound. The imaging for suspected patients, taking into account that the first PCR is available in our hospital 12 to 18 hours after the sample. We do a bedside chest X-ray in isolated rooms in the context of the emergency department, or upright chest X-ray in the radiological department, depending on the patient condition. If the chest X-ray is positive, no other imaging. In the rare case the chest X-ray is totally negative, we have a consultation with clinicians, evaluating symptoms, pulse oximeter, and so on, and we go to CT, but with a problem less than 20 or 25 CT. The good news is that up to now, we didn't have any radiologist or technician infected. That is a good thing in my view. Next slide. What are my impressions? First, very good news, a decrease of the admission rate to the emergency department, emergency room in the last 2-3 days. I don't have precise numbers, but over 65% of the chest X-ray are frankly positive, 50% or positive, 25%. Clinical symptoms and pulse oximeter are important for decision-making in the case of negative chest X-ray. The crucial point is that the reference is neither gold nor standard. So we have to consider this because it is very important. My impression is that imaging does not seem to play a relevant role for prognosis or decision-making, with some exceptions I will show you. And we have to pay attention to asymptomatic patients, especially cancer patients. And we now are looking in background, in retrospective, to evaluate, re-evaluating the CT scans since December 1, 2009. 2019. Next slide, please. This is a typical a case I want to show you, because I had other cases, but it was not possible to upload due to the size of the images. So you see the story. I don't want to waste a lot of time, but the story is that this chest X-ray was considered as negative, even though discussing with my coworkers, most probably we have to think that this was positive. But the standard was the PCR was positive on March 5, negative on March 14, weekly positive on March 24, and negative on March 28. So if you look at the story, I had a series of radiographs, but what happens is that the patient was on March 11, also considering the level of interleukin 6, and the clinical condition was transferred to the intensive care unit, had mechanical ventilation, and on March 24 was transferred to the internal medicine department. But next slide. So, but I'm not able to show you all the series, but believe me, there is not a so strict correspondence between the chest X-ray and the clinical condition. So we suspect that there is a possible role for pulmonary microembolism that justify the clinical condition and the necessity also of mechanical ventilation in these patients. So it's difficult to find a high correlation with the imaging. Next slide. What we are trying to do in very few cases up to now, because is to give the anesthesiologist, the intensive care people, the evaluation of the expansion of the lung, comparing different PEEP pressure. You see what the change with a gain of 200 milliliter increase in total lung volume, changing from 10 millimeter from 8 to 10 millimeter AG. So it is possible, perhaps, that we can help in choosing the right pressure or to make some decision making in the intensive care unit. But this is only a project, not day-to-day clinical practice. Next. So we are retrospective reviewing CT scans performed before the first official COVID case reported in Italy, that was mid-February. And as you can see, this is one of the cases in which on January 31, we had some unexpected finding in the lung in a CT performed for fever and abdominal pain. And we suspect, we are reevaluating these scans, that also already in January, mid-January, and so on, we had probably cases of COVID coming from the red zone, from the zone that subsequently become the red zone. Next one. Finally, I want to add 2 or 3 other considerations. One was shared with Professor Derki today morning in a long phone call. The first is that for radiologists, there is a potential important role considering COVID-19 as a multisystem disease. This was a case published by the group of Roberto Maroldi in Brescia, in which we have an important involvement of the heart with a myocarditis in the context of coronavirus disease. There is problem of probably brain involvement, kidney involvement, and so on. Next slide, please. Another consideration is that we have to consider that the validity of a diagnostic test is not easy to predict, because we are living in a different world in which the change in prevalence change the sensitivity and the specificity of the test. Next one. Finally, we can use probably some index this was a paper already from the group of Brescia describing some score for grading the involvement of the lung on the chest radiographs. And probably these are times in which the finite life is, in which we can apply artificial intelligence to chest X-ray in order to allow to offer a second opinion to radiologists, especially for radiologists in the location in which the pandemic will appear in the next months or in the next weeks in the world, and they will be in some way, could be in some way aided by some artificial intelligence too. That's all. Thank you.
Thank you, Francesco. You've dealt with a lot of issues there that are really interesting, and I'm sorry we won't have the time to tease them all out. But in fact, I've been monitoring the questions coming in online as you've been speaking. And interestingly, you've dealt with quite a number of them. We've been asked about the multi-system nature of the infection. We've been asked about thromboembolic disease in the lungs. We've been asked about scoring scales for you've dealt with a lot of those. And I might put this one to Nicola. A viewer from the US, Mario, says, I've had a few younger patients in their 40s and 50s present with back pain rather than breathing difficulties. Have you noticed any significant percentage of your patients presenting in this way?
Back pain, yes. I still can't understand the reason why this symptom is not so infrequent. So, frankly speaking, I said before that we used to evaluate patients with moderate to severe symptoms, patients with pulmonary damage, but we also consider imaging for patients with atypical symptoms. Particularly at the beginning, we ignore the forms, the spectrum of clinical manifestations of this pneumonia, and the back pain, of course, was reported not infrequently by patients, also with mild fever, and I can't tell you the predictive value of this symptom, but it was interpreted as an atypical symptom, and some patients were also obtained also some imaging tests.
Thank you. And we may come back to that point, patients presenting with atypical symptoms, in a moment, because there's another point I want to bring up. But before that, can I ask, firstly, Nicola, another question. Can any conclusions about the likely prognosis of infected patients be drawn from the initial CT appearances and the percentage of lung parenchyma that's abnormal?
That's a very, very good question. I think there's no data about fine prognostication. So literature is flourishing, but we need more time to actually understand. But it is worth bearing in mind that imaging is a single moment through the clinical path. So in this specific setting, the prognostic value of a given CT image or chest X-ray image, because also chest X-ray can tell you the point of the disease, as Professor Sardanelli pointed out earlier, maybe is not so valuable, I think. I think we need to wait for robust data to understand the individual prognostic value of CT indexes or chest X-ray indexes.
Can I comment?
Thank you.
Adrian? Can I comment
Please.
on this? Asking in particular Nicola, that is a real expert in this field. My impression, my sensation is that if a prognostic value is possible to be obtained by CT, I was thinking about dual energy, contrast enhanced perfusion CT in order to see the iodine maps and to make a kind of mismatch between, to have a functional evaluation of the parenchyma, also in terms of perfusion. But the problem, and I don't know what Nicola and you think, is that to administer the iodinated contrast agent in these patients could be not a good thing to do. So I think that prognostically speaking and also clinically speaking, to have an idea of the perfusion and not only of the size and the expansion of the parenchyma could be good, but it's quite difficult to use contrast in this patient. What is your opinion, Nicola, about this?
Thanks for asking this very important question. I think, yes, unfortunately, renal failure is a complication of coronavirus, of this infection. So we need to be very careful in using the iodine or contrast in these patients. However, we used to scan patients for pulmonary embolism, and we had to use, of course, contrast. And we also tried some dual energy protocol in these patients. And I think dual energy, so the assessment of iodinated map may be biased by the presence of lung infiltrates, ground glass, and consolidation. So the interpretation of pulmonary of the iodinated map is quite trivial and tricky somehow. So as you mentioned earlier, it would be more fascinating probably to focus on the cardiac abnormalities, and we do increasingly see cardiac abnormalities, right heart abnormalities in patients, in very critically ill patients. And we do also see some peripheral vascular abnormalities in subjects with very bad disease. And these vascular abnormalities consist of peripheral branching opacities connected to the vascular structures, and some centrilobular nodules, again, connected to the vascular structures. I think further data for sure are, again, needed to correctly interpret these atypical findings, and they might be related to vascular abnormalities in patients with severe pneumonia.
Thank you.
A question I'd like to put to both of you, and perhaps you first, Francesco. We're hearing reports of patients who present with relatively mild symptoms, have a positive PCR diagnosis, are managing perfectly well at home, and then about 7 to 8 days after diagnosis present with rapidly worsening respiratory conditions. How frequently have you seen this, and do they always have imaging abnormalities when they come back?
Well, I don't have data about this, but I think that some cases of this probably happen. It is a possibility to be taken into account, absolutely. Now we are starting in analyzing also patients that were healed and then come after 15 days after the quarantine, the home quarantine. So this is another word to be discovered. But I think this is a real possibility in practice. I don't have data on this, but it's possible.
Nicola, have you any thoughts on that, on people presenting much worse after a week or 10 days or 15 days after diagnosis?
Yeah, for sure, imaging is prone to false imaging, to false negative as well. And this is also true for CT. And we sadly seen some patients with with normal CT scans, and they came back 7 days max, so with a very bad pneumonia. So, and the CT was entirely normal at presentation at baseline. So, but I can tell you that this happened, fortunately, in a very small minority of subjects, and that happened within a few days, and not after after 2 weeks. That usually happens. Our cohort of study cohort in our patients within 1 week.
This happened with a colleague of our hospital, but if I'm correct, no more than 3 or 4 days in time, in different time, in interval time.
Nicola, I'd like to put a question to you that I put in a slightly different form to you last week, and I think things have somewhat changed in the interval. We talked about last week about surgeons seeking chest CTs on patients who presented with abdominal emergencies in order to assess the lungs prior to surgery or to look for atypical presentations. Since we spoke about this last week, a number of surgical academic bodies have issued recommendations that in all cases presenting with abdominal emergencies who are going to surgery, a chest CT should be obtained regardless of whether they have chest symptoms or not. Have you any comments that you might like to make after the past week?
Thanks for asking. So yes, I remember I had stated that we did not add chest CT in those subjects. In fact, we had been looking at the lung basis to identify any lung abnormalities suspicious for unknown COVID pneumonia, as we do for any other incidental finding in routine daily practice, as incidental findings, of course, are an issue for radiologists in daily practice. However, I have to confess that I've changed my mind, as we have been facing an increasing number of these case scenarios. We are now including the chest in those CT examinations, especially as a clinical inquiry from surgeons.
I think this seems to be a reasonable strategy. Our surgeons are looking for it, and it's not unreasonable, I think, to help them in this way.
Adrian, I think that this is an open issue. But what is important, in my view, is that the value of the preoperative chest X-ray has totally changed now. Because in the past, the preoperative chest X-ray was a routine, usually acquired because of the necessity to have the comparison with the previous chest X-ray. It happens in my hospital that these routine chest X-ray for patients that were operated, not COVID patients, were operated for urgent intervention for prostate or for something else. The preoperative chest X-ray become an object for discussion because now we report with a lot of attention to minimal signs, and this opened the issue of to be sure or not sure that the chest X-ray is really negative, because in the case you see anything, this open the way to CTE and open the way to try to be sure before admitting a potentially positive COVID positive in the department of urology or abdominal surgery or cardiosurgery or whatever. And I think this will be a big issue in the next future, because we know that probably the number of positive persons is much higher than what we know, and they will be in the future potentially patients, not COVID, but if they are positive, this is a danger for the operator, for the physician, for the nurses, and for the other patients. This is a big issue on which we have to work in the future. Probably making more CT for confirmation of very subtle findings in the chest X-ray than the CT that, at least in my hospital, we are doing now for the diagnosis of COVID patients, I think.
Yes, I think you put the point very well. COVID or coronavirus infection is not going away. It's not as if in 6 weeks or 2 months this problem will disappear. We will have this virus endemic within the population for the foreseeable future. So we may well find ourselves under pressure to do CT preoperatively in patients in whom we would not have done it previously for exactly the reasons you both expressed. I've got a question here from the audience I'd like to raise with you. A significant proportion of deaths from COVID occurs in patients with pre-existing health conditions. In your experience, are these pre-existing chronic lung diseases, or is it more often coexistent non-respiratory conditions such as diabetes, immunocompromise?
I have no answer for this. I don't know if Nicola, but I want to highlight data that were given this morning on the TV by the governmental authorities in Italy, patients who died for COVID-19, in 52% of the cases had 3 other comorbidities. In 25% of the cases had 2 other comorbidities. In 21% of the cases, that totaling 98 in overall, they had at least one other comorbidity. This means that comorbidities are the key factor for dying from this disease. And this, in my view, opened a big discussion about a necessity of a crossing borders between medical specialties and crossing borders between subspecialties in radiology. This is my view. That is a word that is changing now.
I've had a question about multisystem disease and in particular pancreatitis due to COVID. The questioner mentions that they've had one colleague with a diagnosis of coincident pneumonia and pancreatitis. Have either of you seen similar cases?
No,
yes,
not for what I remember. You see?
We have seen one case, but that was interpreted, was quite controversial. We thought that could be a side effect of the antiviral therapy.
Okay. Thank you.
We've
had a question. We've had a questioner from Luanda in Angola contact us asking about transportation of patients to CT without there being a biohazard to others. Now, this is a topic we hope to deal with in greater detail in week 3, a week from today in the next area. But do you have any quick comments about transportation and staff and other patient protection?
So I think we touched on this last time. I think we talk about protection, so the equipments for patients, so surgical masks, the gloves as well. So, but specifically, I don't have any advice for transportation, honestly speaking.
Yeah, as you say, I think we discussed this to some extent last week, and it's basically the standard recommendations from the ECDC and the WHO that most hospitals are following if they're able to do so. We mentioned back pain earlier. A questioner has asked, could back pain be due to kidney failure? Is there any association between those patients who present with back pain and renal dysfunction?
I don't know.
Yeah, like many things, I think in this condition, we're learning as we go along, so we may not be able to answer everybody's question. So
this morning with Professor Derki, we imagined the potential for using ultrasound for evaluating the renal function in these patients, but you know, making ultrasound in these patients is a not trivial task, avoiding to be infected and so on. So it's something that has to be investigated if there is a real balance in favor of this approach. When we have data about GFR that can suggest us to go to a deeper evaluation of the kidneys.
Yeah. Another questioner has asked if there's a database of X-rays and CT scans of COVID positive and negative patients with confirmation by PCR diagnosis as an educational tool. I'm not sure any organization has yet produced such a database because this is such a changing and rapidly fluid environment. But increasingly, most of the journals are producing papers with nice examples of what to expect. So I direct the questioner perhaps to the literature for that. Papers are appearing online almost on a daily basis that are very helpful. Someone has asked, are there any findings that neuroradiologists should be looking for? I'm not sure if they're asking about neuroradiologists who are being redeployed to become chest radiologists, or neuroradiologists looking at neuro studies.
So I think, of course, brain vascular injuries have been reported. The rate seems be increased or higher in COVID patients, but it's just a suggestion. So I don't have any specific suggestion for neuroradiologists unless just to look at the lung apexes. Again, when scan the patients on CT, for sure, if they include the lung apexes in their examinations, again, to identify subtle unknown COVID pneumonia.
There are many
another question I'm gonna...
No, there are many things
Please,
we
go
don't
ahead.
know. For example, what is the correlation in brain MRI with anosmia and ageusia, that are symptoms that are reported by these patients? There is we don't know what happens in terms of duration after the healing, after negativization of PCR of these symptoms, and if there is any correlation with olfactory bulb imaging or with microbleeds or other findings in the brain. This is a completely unexplored territory of the future, I think.
We're going to have to finish shortly, but can I just ask two brief questions that have also come up? One is, have you experienced any evidence of pericardial effusion or cardiac tamponade in COVID pneumonia patients?
Yes, pericardial. If you have seen sporadically pericardial effusion, and pericarditis is supposed to be another comorbidity, again in COVID pneumonia. And I can tell you that I've seen just small, very tiny pericardial effusion, never seen massive pericardial effusion in our patients.
Thank you. And
not in patients for which the initial diagnosis were COVID, but possibly in patients that had a previous cardiac problem.
Thank you. And perhaps one more question for you, Francesco, and I think I know the answer to this one. Somebody has asked, what is the role of postmortem in COVID-19? I suspect they're not being done.
We have colleagues at the University of Milan that would like to start on this virtuopsy with CT, but for many technical reasons we didn't start up to now. I think that for the future it could be certainly an idea to use CT in order to see the lung condition for autopsy, but I have no particular information on this up to now.
My suspicion is that very few postmortems are actually being performed in these patients simply because of the overwhelming nature of the pandemic, and hospital services are having difficulty enough coping with the numbers of living patients and attempting to save them. Finally, for both of you, do you feel that the slight flattening of the curve of new cases that we've seen in Italy in recent days is encouraging? Do you see a little bit of light at the end of the tunnel?
Yes, I think we have reached the peak. We have seen again another decline since the last week. So now the number of CT and chest Xray examination decreased by more than 50%. But I want to keep my fingers crossed, of course. I think that we have the feeling that restriction worked very well, but I think the way to see the light at the bottom of the tunnel is not so close.
I completely agree with Nicola. I think that we have to ask epidemiologists to do their work. I only remember historically that the most number of deaths for the Spanish influenza 100 years ago were not with the first wave, but with the second wave. Now we are living in a different world. We have research, we have medical staff, we have a lot, but don't forget that the second wave of the Spanish influenza in 1918 was with the second wave. So pay attention.
That's a sobering thought, and let's hope we don't see a repetition of a second wave that's even worse than the first. I'd like to thank you both very much for taking the time again, Nicola, this week, and to you also, Francesco, for joining us. We're very grateful that you've been willing to take time and share your experiences with us and with the audience, and to answer so many questions which people have. We will be having another episode of this podcast series, or this broadcast series, next week, during which we'll be talking to colleagues from Spain and France, two other European countries where the numbers of infected patients are very high, particularly in Spain. And we're going to try and focus on some other aspects of how radiology departments can manage during this pandemic that we haven't dealt with last week and this week. So I hope many of you will be able to join us again next week, and we'll explore other aspects, as I said, and please keep the questions coming, because we want to respond as rapidly as we possibly can to the specific issues you want us to deal with. So thank you all very much, and thanks to our guests, Nicola and Francesco, again for joining us today. We'll hopefully see as many of the viewers as possible again next week. Bye-bye.
Thank you very much.
Bye. Bye.
Thank you.